Here is a detailed explanation of the physiology of bile, including its composition and functions. Physiology of bile. Bile is a yellow-green, alkaline fluid produced continuously by hepatocytes, liver cells. It plays a vital role in digestion, especially of lipids, and in the excretion of waste products. After production, bile is either sent directly into the duodenum or stored and concentrated in the gallbladder for later use. 2. Composition of bile, detailed. Bile consists of both organic and inorganic components. A. Organic components, 97-98%. 1. Bile acids or bile salts, 50%, derived from cholesterol in the liver. Primary bile acids, cholic acid, and chenodeoxycholic acid. These are conjugated with glycine or taurine to form bile salts. Emulsify fats and facilitate micelle formation for lipid absorption. 2. Bilirubin, 2-4%, a yellow pigment from the breakdown of heme from hemoglobin, conjugated in the liver to become water-soluble and excreted in bile. Gives bile its yellow-green color and feces their brown color via urobilinogen. 3. Cholesterol, 1-2%, insoluble in water but made soluble in bile via micelles. Excess is secreted in bile as a method of cholesterol elimination. 4. Phospholipids, mainly lecithin, 20-40%, amphipathic molecules that aid in fat emulsification, help solubilize cholesterol to prevent gallstone formation. 5. Proteins and amino acids. Albumin and other proteins may be present in small quantities. NACBI, inorganic components, 1-2%. Electrolytes, sodium, NaCm, Kpi, calcium, silicate, chloride, bicarbonate, HCO3-. Bicarbonate helps neutralize gastric acid in the duodenum. The ionic composition varies depending on whether bile is stored in the gallbladder or freshly secreted. Functions of bile detailed. 1. Emulsification of fats. Bile acids are amphipathic, having both hydrophobic and hydrophilic parts, allowing them to break down large fat globules into tiny droplets. Emulsification increases the surface area for pancreatic lipase to act, improving fat digestion. Absorption of lipids and fat-soluble vitamins A, D, E, K. Bile salts form micelles with fatty acids, monoglycerides, cholesterol, and fat-soluble vitamins. Micelles facilitate the transport of lipids to the brush border of the intestinal mucosa for absorption. 3. Excretion of waste products. Bile serves as a major route for excretion of bilirubin, waste from RBC breakdown, excess cholesterol, xenobiotics, drugs and toxins. These substances are not excreted via urine due to their lipophilic nature, so bile is essential for their removal. 4. Neutralization of gastric acid. Bicarbonate ions in bile help neutralize the acidic chyme entering from the stomach. Creates a suitable pH 7-8 in the duodenum for digestive enzyme function, especially pancreatic enzymes. F5. Antimicrobial action. Bile salts can disrupt bacterial membranes, preventing bacterial overgrowth in the small intestine. IV, bile secretion and flow. Steps in bile formation and secretion. 1. Hepatocytes produce bile continuously. 2. Bile flows through bile canaliculi, intrahepatic bile ducts, common hepatic duct. 3. From here, it either goes directly to the duodenum, especially during digestion, or enters the gallbladder for storage and concentration during fasting. Hormonal and neural control. Cholecystokinin, CCK, released when fatty chyme enters the duodenum, stimulates gallbladder contraction and relaxation of the sphincter of Oddi. Secretin stimulates bicarbonate secretion in bile ducts. Vagal stimulation enhances bile secretion during the cephalic and gastric phases of digestion. V. Gallbladder's role in bile physiology. Stores bile between meals. Concentrates bile by absorbing water and electrolytes, up to 10x concentration. Contracts in response to CCK, releasing concentrated bile into the duodenum. Clinical relevance. Disorders of bile function include cholestasis, impaired bile flow, jaundice, fat malabsorption, gallstones, cholelithiasis, imbalance in bile composition, e.g. excess cholesterol or bilirubin, malabsorption syndromes, inadequate bile, poor fat digestion, and fat-soluble vitamin deficiency. Jaundice, elevated bilirubin due to hepatic dysfunction or bile duct obstruction. Conclusion. Bile is essential for digestion, absorption, and waste excretion. Its intricate composition allows it to emulsify fats, aid nutrient absorption, eliminate toxins, and maintain digestive tract health. Any disruption in bile production or flow can lead to significant gastrointestinal and systemic issues. Here are 10 nursing implications and applications related to bile physiology. 1. Monitor for signs of jaundice in patients with liver or biliary disorders. 2. Assess for clay-colored stools as a sign of bile duct obstruction. 3. Monitor fat-soluble vitamin levels, A, D, K, in patients with bile flow impairment. 4. Encourage a low-fat diet in patients with gallbladder disease. 5. Observe for steatorrhea, fatty stools, indicating poor bile secretion. 6. Educate patients on post-cholecystectomy diet and digestion changes. 7. Administer bile acid sequestrants or supplements as prescribed. 8. Monitor liver function tests, AST, ALP, bilirubin, regularly. 9. Prepare and assist in diagnostic tests like ultrasound or ERCP. 10. Provide education on medication side effects that impair bile production or flow, e.g., certain antibiotics or oral contraceptives. Thank you. Have a nice day.